everyone here. So I'll just start with a quick introduction to the panel and an introduction of Dr. Eva, and then I'll hand it over. So hello everyone. We're delighted to have you with us for today's session. The today's session is focused on the role of healthcare data in shaping policy and access decisions in the United Arab Emirates. So today we are witnessing one of the most significant transformation in UAE's healthcare landscape. The integration of healthcare data is not only revolutionizing patient care, but is becoming a powerful force in shaping national healthcare policies and improving access to care. The distinguished panel joining us today will explore the current landscape and the future potential of healthcare data in the UAE. This session will be moderated by our esteemed guest, Dr. Eva Turgoni. Dr. Eva Turgoni is Medical Director for GCC at AstraZeneca, based in Dubai, UAE. She's a senior medical affairs leader and physician with a strong commitment to improving outcomes and health equity across multiple therapeutic areas, and also advancing clinical practice change with science driven and patient focused approaches. Dr. Turgoni has developed global medical affairs strategies and launches for blockbusters, led end to end medical evidence generation, including global phase 3 and RWE studies and international disease registries. Her current work in GCC focuses on pioneering and co creating innovative health solutions, shaping research and policy across the healthcare ecosystem stakeholders. She has built high performing medical teams under her transformational leadership and champions the culture of developing the next generation of medical leaders, putting strong value on a culturally diverse and inclusive environment. She obtained her medical doctorate in general medicine and has a diploma in clinical research and is a registered physician with the General Medical Council in the United Kingdom. She has a wealth of experience obtained at global, regional, and country level roles in GCC, UK, Ireland, Poland, with AstraZeneca, Pfizer, and so with this, I'll hand it over to Dr. Eva Turgoni to take it from here. Dr. Eva, you can take
Thank
it
you.
from here. Yeah?
Thank you for the introduction. All the panel members are excited to participate at the RWEsearch Annual Summit. I'm delighted to moderate what promises to be an informative and engaging panel discussion. And I would like to ask the distinguished panel members to briefly introduce themselves. Dear panel members, Dr. Halima, maybe you can start. Can you unmute yourself? Yes.
Thank you so much, Dr. Eva, for this nice introduction. I am Dr. Halima Al Sabah, Associate Professor at Abu Dhabi University, specialized in public health and nutrition. I have been working in UAE since 2013, and till now I am here.
Thank you. Dr. Husam?
Yes, hi. I'm Dr. Husam Majali. I'm a physician by training, and then I had diverse experience working into the health insurance industry, working with the pharmaceutical industry in market access and insurance reimbursement, healthcare reimbursement, and also I worked with Dr. Sara as the vice president of the Health Economics Society, and I was also chairing the healthcare finance committee in the Farmag in the Gulf. Again, happy to be with you today. Thank you.
Thank you, Dr. Husam. Dr. Sara?
Yes, my name is Dr. Sara Al Dallal, physician by practice, and I have a great interest in health economics. For that, I am based in Dubai, and I'm the president and founder of the Emirates Health Economics Society.
Thank you very much. And finally, Dr. Akram?
Thank you and good afternoon. Pleasure to be here. I'm Akram Bushanaki. I'm the CEO of Jameel Health, which is a healthcare organization that focuses on distributing innovative healthcare solutions to the global south. I'm a doctor in pharmacy by training. I spent all my career in the healthcare and biotech industry in large companies you will have heard of, Bristol Myers Squibb, GSK, Gilead Sciences for many years. Pleasure to be with everyone tonight.
Thank you so much. Let me to start by stating that there is one shared vision that links us panel members together, that we all would like to have a healthier future for all. Today, the aim of our discussion is to provide the audience with an overview about how healthcare data supports shaping healthcare policy and access decisions in the UAE. Our panel will discuss the current healthcare data infrastructure and landscape. We will also talk about how using RWD helping health insurance decision making. I will share some insight about current key healthcare priorities, and also bringing some examples from the pharma industry, how we leverage data to drive policy change. We will also hear about the journey towards the evolution of a more value-based healthcare system, including health economic studies. So let's start our panel by providing some background to our audience about the current healthcare data infrastructure, landscape, and key challenges. I'm turning to you, Dr. Halima. Can I ask you to share with us what is the current state of healthcare data infrastructure in the UAE? How does it support currently data-driven policy and access decisions? And if you could also add some thoughts about the key challenges regarding data availability and quality, and how these impacting policy formulation. Unmute again, yes.
Thank you so much, Dr. Eva. For your question, the first question about the current state of the healthcare data infrastructure. يعني إنه in the UAE يعني إنه my experience in UAE for more than 10 years till now, they have made significant strides in building robust healthcare data infrastructure over the last few years. And it includes also the implementation of electronic health records. Now that we can see that also in several hospitals. For example, in Abu Dhabi, they have the initiative or the platform system that called Malafi, and is one of the region, the first health information exchange that connect more than 90% of the healthcare providers in Emirates. And this platform, it enables the healthcare provider to securely share the patient's information and facilitating also real-time data-driven clinical decision. For example, during COVID-19 pandemic, these systems, they played a crucial role in tracking the infection rate, managing testing, implementing vaccination strategies, also the ability to gather this information and analyze these information also significantly influence public health policies. And during the lockdown also, and they change from, for example, from lockdown to vaccination campaigns. And also in the UAE authority, also they rely on this data and they make informed decisions and according to the resources and the allocation of resources. And for instance, decisions regarding the placement of a new healthcare facility in a remote area or in underserved areas or allocation of medical supplies are often based on the insights driven or derived from these data systems. So these data systems are very important. And also, and as I remember also during the national also health survey that conducted in the UAE, that they use also these data in order also to measure the prevalence rate of obesity, cardiovascular disease, hypertension, all these chronic diseases. And this data was essential also in formulating the UAE national strategy and even the nutrition national strategy that I'm involved also. I am part of the committee, a member of this committee on that, which also targets reducing lifestyle diseases like chronic diseases. But as you mentioned that we have challenges and in the availability and the quality of this data. يعني إنه the challenges is the problem is with the fragmentation of the healthcare data between public and the private sectors in the UAE. For example, here in Abu Dhabi, we have the DOH. In Dubai, we have the DHA. We have the private sectors as well. While the problem that the data, there is no inconsistency between the data in the public and data with the private sectors. For instance, private hospitals, they may not follow the same data entry or protocol like what the public do in the hospitals. This leads to discrepancy in the data and the quality of the data. And this impact the ability also to create unified national health profile, which is essential also for informed policy decisions. So when the data is not shared across the system, it affects also the accuracy of the national health reports. For example, if the policymakers rely on the public data only, then the national then they underestimate the prevalence rate of these diseases, and this could result in underfunding that aim to early detection and prevention of these chronic diseases. And as I mentioned, according to the quality, the inconsistency in the quality of the data across also the healthcare provider. Some, for example, small clinics or hospitals, they may lack of the infrastructure or the standardized processes to ensure accurate data collection. For example, also, if the patient seek care at multiple institutions in UAE, more than one, or private and public, there might be also a gap in their medical history. And if those also institutions are not integrated into a unified platform, and this can also make skewness in the data and resulting in also less accurate policies, especially when collaborating, also allocating resources for chronic diseases. So inconsistencies in how data is collected or entered and maintained can lead to inaccuracy. For example, some healthcare facilities may not regularly update the patient's records, or they may omit some of the information from the system or the family history. So these gaps directly impact data reliability. And because these are like confounding factors that we need also to understand them, that may lead to increase or decrease the effect, because we need also to understand these determinants of health. If the data, for example, on the prevalence of non-communicable diseases like diabetes is inaccurate, it could lead to underestimate also the demand or the healthcare demand for the NCDs, or for these also to fund the diabetes care program and the diabetes management. Then it will affect also the policies. And also it can cause also mismatch between the allocated resources and the actual demand of the population for that. And يعني no, maybe these are most of the challenges. I'm not sure what is.
Yes, thank you for the very comprehensive response. Maybe if you can share your opinion about implementability. So how ready are stakeholders in the UAE healthcare sector to embrace this data-driven approach to policy and decision making?
Yeah, thank you very much for this important question, because the stakeholders, we have first of all to introduce or to identify who are the stakeholders. Stakeholders, it includes the government officials, decision makers, the healthcare providers, the private sectors, and these stakeholders, they recognize the importance of using data-driven for decision making. So the public sector, particularly the MOHAB, the Ministry of Health, have been proactive in promoting the culture of data utilization. And it is evident also by national initiatives like National Strategy for Artificial Intelligence, for example, and for using big data analysis. But there are also some kinds of variation between the public and differences between public and the private. So public hospitals are generally more aligned with the national initiatives, whereas the private healthcare providers, they face several barriers of that. I can mention some of these barriers that, for example, technical expertise. They have lack of skills in data analysis and also in health informatics. Maybe they how to use the data, how to analyze the data. So maybe they need capacity building and the training on that. Also financial issues and financial constraints, in addition also to the privacy concerns, because some of these stakeholders, particularly in the private sectors, they afraid or they hesitate to share their data due to concerns over patients' privacy and protocols. They are afraid that they will breach the data protection laws of the patients and the privacy and the data security. So healthcare providers are hesitant to share data to this platform due to fear of non-compliance also with data protection laws like the UAE's personal data protection law. So overcoming these challenges will require also clear regulations, incentives for data sharing and training programs, also to upskill healthcare professionals in data analysis. I hope that I answer your questions.
No, thank you so much. Yes, you did indeed very comprehensive responses, Dr. Halima. To continue the flow, I was going to address in the panel Dr. Husam Majali. Dr. Husam, are you still on the call? Because I saw that maybe there was some technical difficulties. You are here. Excellent. We would like to continue thank you. We would like to continue the discussion, understanding the efforts towards using local healthcare data for reimbursement coverage decisions. So I would like to ask you to share with us that what is the current status and trends using RWD in health insurance in UAE, both in the public and the private sectors. And if you could also share that what are the, similarly to the previous talk, the facilitators and barriers for the wider use of RWE in health insurance in UAE.
Yes, hi, Doctor, and thank you for the opportunity to speak about this highly important topic in health insurance, both public and private. Real-world data, real-world evidence, actually, it's for health insurance, it's not something new. I mean, in our region, we just started to hear about it in the other aspects like the research, like using for health outcome or designing the policy, but health insurance data or real world data and evidence was used in health insurance for decades. And that at that time was used as trends or analytics of the outcome, the real outcome of the healthcare process. So if you go and the administrative claims data, everybody agrees that this is one of the most accurate sources of real world evidence. So again, administrative claims data is extremely important because it's an actual representation of the healthcare service, process, and outcomes. So you can come up with how many breast cancer case in your population, or how many they are receiving that type of therapy and health outcome. So the real world evidence in health insurance is extremely important, and it's used almost daily on the decision makers in the health insurance, both in public and private. If you want to design in the public sector, for example, if you want to fund a specific area in your healthcare, you want these real world data to be there to understand what's the needs of your population, actual needs, not only on theoretical aspects, because sometimes the incidence of diabetes in your region is different from the global incidence. So real world data is used for the policy. That's very important, and it's becoming more important, as Dr. Halima said, because we have now, for example, we are lucky in UAE and the Gulf, we have one of the most accurate platforms or sources of real world data, the Malafi, the DHA data claims, or EMRs. We are very advanced in EMRs, electronic health records, electrical and medical records in hospitals. So the trends is using it in policy, in health insurance, in private health insurance. We use it for, or it is used for cost containments, for decision making. So eventually all the fraud, abuse in the health insurance are generated from the data, from the real world evidence. The health insurance also, the pricing of their products, they know if they have a population that has so much high incidence of disease, so they will do different pricing for their products. So the trends are using it more efficiently, more common than before, because now we have trustful sources of these real world data in our healthcare system. So there are increasing utilization, increasing into building even guidelines. What are the good or bad things for our healthcare system? Now the decision makers usually they have an evidence-based policy change. Nobody now relies on into international standards. If you talk about health economy, nobody now use, or more we use our local data, and I'm sure that Dr. Sara will speak about it even more evidence-based. So I think the health insurance used one of the areas that real world data is heavily using the real world data. As I said, in claims management, more cost optimization, pricing of the products, design of the products, specific each group of patients or people will design different product base. If you have a policy or a group or a region that has more demands for dental cover, then we will design the products based on that. So these are the trends are most we notice in the health insurance. It's more utilization and it's more evidence-based.
And can you please expand on a bit that how these coverage decisions are made in the UAE?
Okay, for example, the coverage decisions, if there is a special need for a specific treatment. For example, I will describe the experience with DHA. There is a need for flu vaccines, and the real world data showed us that there is a need for protection for that, against that disease. Then we will put into the policy, the private health insurance policy, to cover this vaccine. If the health insurance, for example, see that a certain specific treatment, for example, glucose monitoring, continuous glucose monitoring, if that will help them scale the cost and provide better care, then they will put it into the policy. So the coverage will depend on to the trends that are detected through the real world evidence and research. You don't cover something that you don't need or will not help your patients. You design your policy, you design your benefits based on the actual needs of your patients. Again, for example, if you see that there is a trend for or there is a new therapy, a new innovation in your service, and it is helping the patient survive more with better quality, you include it into your coverage scheme for these patients.
And is in a 1 minute you can summarize what are the key recommendations you would have for improvement?
Okay, that's a great conclusion. I think the most important thing that we should believe in the value of real world evidence and look for these sources continuous. We always have some hidden resources that people will get benefit of it, and utilize these into more of our decisions and studies and research. I do believe in the value of real world data, and I think each decision makers or even the simple people on the ground should use it. So real world data is very important for all our aspects, not only for research and study. Thank you.
Thank you very much. Thank you for these comprehensive responses again. Now we are continuing with the third topics of this panel discussion, where first I would like to discuss some current priorities for healthcare systems in general, including the UAE, and then give some insights about how the pharma industry is leveraging data and technology to drive access and, of course, patient outcomes. As you are all aware, after the COVID-19 pandemic, the healthcare ecosystem stakeholders realized that no one can work in isolation. It's all about co-creation and collaboration to ensure healthcare system sustainability and resilience. Because of the reason behind this, because the complexity and the scale of the common challenges of the healthcare system across the world are very similar, actually. There's huge morbidity and mortality burden from common chronic NCDs, as you are all aware, and this impacts the increasing aging population, which of course puts a very big pressure on the primary care or family healthcare system levels. But of course, at the same time, there are long waiting lists at the specialist level, and this is due to the lack of capacity. And all of these puts, again, an increasing financial burden. From the aspects of opportunities, there is absolutely an exponential technological acceleration with new drug development platform and new treatment modalities are becoming available, and also AI is here around the corner to be leveraged. So for these reasons, we in the pharma industry now are thinking rather about providing comprehensive healthcare solutions across the patient journey. So we often say, which is now sounds like a cliche, but we try to move from actually sick care to real healthcare by trying to advocate very important things. Number one is early disease risk identification, then earlier disease diagnosis, earlier treatment, and focus on much more on prevention and precision medicine than used to be. And also, as a new trend, beyond thinking and focusing on patient outcome, we increasingly thinking on generally health equity. And this has critical importance in the Middle East and the UAE, for example, by improving clinical trial and data equity here. As a second thought, I would like to a little bit touch upon how we generate and leverage data to improve policy and outcome. We all know that for a well-functioning healthcare system of a country, you need basically 4 key items. One is an adequate infrastructure. 2 is guideline treatment and guideline adoption, international guideline adoption at a good level locally. Third is that we need to collect and analyze data from running national disease registries and national quality improvement program, so that we can assess the KPIs and outcome at a continuous and long-term basis. And the fourth is, of course, very important, is that underlying all of this, to having health policies and regulations to support the implementation of this above three. We all know that the UAE is very good in number 1 and 2, very good adequate infrastructure, very good guideline adoption. However, in terms of both randomized controlled trial data and real-world evidence data, the data availability is low or patchy. And this is not just true for the UAE, but generally for the Middle East. So to fill these data gaps, we start the evidence generation in the pharmaceutical industry with understanding very carefully the unmet local needs, and followed by figuring out how can we fulfill this data gap. It's very important to distinguish between clinical evidence and payer or access directed evidence. And most recently, since a year ago, we started to generate policy directed evidence as well. And this is because beyond clinical evidence, we need to ensure that our real-world evidence data talks to insurers, access decision makers, health technology committees, but also to government officials, public health stakeholders, and these will drive policy decision making, policy reform, and policy change in general. Also, increasingly, as we're shifting towards precision medicine, and this is now a reality because we have this licensed drug available here in UAE, we increasingly need data on very specific subsets of patients in a much more granular level than used to be, to understand how specific genotypes links to phenotypes. Let me finish with a few examples. If we start zooming from out to in, at a global level, as you know, major NGOs like WHO has, for example, Global Breast Cancer Initiative, and this provides guidance to governments across the world how to strengthen diagnosis, treatment, detecting breast cancer, and this is based on a large, robust real-world evidence. The goal is very impressive, for example, to reduce mortality annually by 2.5%, which over a 20-year period would save 2.5 million lives. Zooming closer to home, in the UAE, most recently, the National Breast Cancer Guidelines for Screening and Diagnosis were updated based on careful understanding of the local data gaps. We at AstraZeneca, for example, building now, supporting the building together with Abu Dhabi Health Data Services, a national quality improvement program and breast cancer research platform based on the electronic health record Malafi in Abu Dhabi. This system will enable breast cancer management and treatment outcome follow-up at a continuous long-term basis. Another example I have from Saudi Arabia, at Al Faisal University, we are enrolling 500 patients using a novel risk identification tool, and looking at, with the use of low-dose CT, how to detect pulmonary nodules in lung cancer. And in combined with the study, we're running a cost-effectiveness study to determine the economic burden of not screening. And with this, we're hoping that we will be able to drive detecting lung cancer at earlier stages as well. The final quick example here would be also that we have supported the creation of impact and inside CKD, these two large micro simulation based reports, which use real world evidence in CKD in UAE and in Saudi, and helps to identify the future avoidable cost of hemodialysis. So I hope with this I have to substantiate what we're doing now. And now I would like to continue the conversation about the evolution towards a more value-based health system to understand how far we have progressed. Dr. Dallal, can you highlight for us what are the major success factors in implementing value-based healthcare?
By Dr. Sabah, and also by Dr. Husam. So to have the success factors of a value-based healthcare is to look at multiple areas. And the first one is that data-driven decision making. So as you mentioned, there is a policy way where you want to have all of this data to make a decision-making process much more easier at the end of the day. And why do we need that? Is to optimize patient care and reduce cost as an overall burden. So if we have certain success factors such as data-driven decision making, that would make it much more comprehensible. This is on the big overlay or layer, but also I will touch upon multiple things that would require to have that success factor really working out to the benefit of having a very comprehensive value-based care. The main important part, which rarely I hear people discuss about, is how we want to coordinate and collaborate between multiple stakeholders here. So there might be someone who is in the middle of this, and or he or she is the most important partner in all of this, which is the patient. But once we keep the patient in the center, and I don't like calling it patient-centered care, but it will be patient-centered value-based care, where we want to know the value that is really pertaining to this patient, but while we're collaborating all together to make sure that this patient really gets towards the best outcomes and the best patient care, keeping that in mind. So to have a very successful value-based care, data is something that we need to talk about. But if we don't have that in a coordinative or collaborative way from each angle, that would be something. The other part where we saw that there are multiple success factors, and we are glad and happy to see AstraZeneca have also thought about looking at risk and stratification and population health management, and doing it on a certain population level with certain focus group, that will make it much more easier and implementable. I don't want to take more, but if you want to give me one more thing with having a success factor for a value-based care, is to look at aligning what could be a best way of having these incentives that we will gather from getting the value-based care working, and having some payment changes that will ensure everyone is collaborating and also delivering an innovative way of really taking this on a different level and a different pathway. So these are let's say, if I will talk about it in general, the big umbrella is to have data driven, all the technologies, all the inputs coming together. But even if I have it on a platform, and even if I say I want to do all of this, for decision makers to have that really a good input, we need to think about the patient being at the center of the circle and having all the collaboration. We need to verify what do we need to measure and what not to measure. And we need to think about risk stratification. How do I stratify? What should I measure and what shouldn't I measure? And at the end of the day, getting that data and getting all of those inputs to really get out with a package of incentives and a package of um, way forward on looking at how we can make the best use of the resources available.
Thank you. Thank you for your response. And if you could also share with us the best lessons learned from implementing health technology assessments.
So that is really interesting. And because of the region and all of these dynamics, I will just take a couple of things to talk about HTA on a global level, and then to talk about how could things be done in a best way, or the lessons that we can learn from the global platforms that we have. The first thing is that there was a common language. Once we started understanding what HTA is and how we want to bring in and enhance some decision-making processes, then there was a structure, let's say, of what to be done and who should do what and where it should be verified. So all of these checkpoints, it was very clear, and the policies were designed in a way to support the verification or giving that HTA process a weight in where it will lead to decision making. That's the first overlay, that there was a common language, and what language we need to decide on was a bit more clear, whereas maybe previously it wasn't that clear. There's other things is, with this common language, it started to have that more, and we can see that the way that the engagement of different stakeholders was much more formalized, and this was easier to pick on and think about what kind of engagement, when to be involved and how to be involved, became a bit much more smoother with the implementation and integrating this in decision making. But to have that stakeholder engagement available, there was also a big shift in the culture, in the training, in the skills development, and having all of that set out and layered out. Now, this is in part of what is HTA and how these HTA formats, and these are the lessons learned. If we want to do it, is have one common language, is bring the tone up and get everyone up with you from different stakeholders, and try to assign roles and get the process much more clear. But there is other things that also was best lesson learned to take from and to adopt. So HTA cannot work for everything and anything. So there should be some, I would say it like approaches that are tailored, that are specific to specific healthcare context, to specific areas, to specific challenges, to specific demands that the patient would be benefiting from. So if a process is much more delayed in certain areas, it may not impact other areas. And specifically, if we want to be, what I'm trying to say is not to be rigid, but to be very much adaptable and to change accordingly, according to the case. Now, again, I want to re-emphasize the patient engagement is crucial with HTA. Having an HTA process and not listening from the patient, as we mentioned with the value-based care as a success factor, may not put the last piece of the puzzle, where we see systems having patient engagement, having patient groups being and sitting on the table when decision making are happening, is one of the, let's say, success factors that we see for that. And finally, that I want to re-emphasize and emphasize again and again and again, is that there should be some clear communication, clear transparency with the process itself, and from how we need to get the data, generate the data, and make that decision making very clear to all parties at any point. So these are, I would say, that main takeaways that we have seen with multiple system with HTAs and developing HTA system that we can take, adopt, and really formalize to really go through that to go through that way to reach to the value-based care systems that we would like to achieve in the region.
Thank you very much. And if in 30 seconds you can go on the hypothetical journey that what if systems did not adopt value-based healthcare principles, what would happen then?
Basically, if we keep doing things as we do, then at some point our healthcare system will be depleted from resources. And on the other end, we might not reach the ultimate healthcare outcome. And then the user in this case or the patient will not be satisfied. And we will be basically going into constraints and may not deliver the best outcomes out there, which we achieve. All of us want a healthier and more happier communities and patients.
Thank you very much for the comprehensive responses. So let's turn to our final speaker today, Dr. Akram. Can I ask you the question of how can the UAE with its healthcare data contribute to the global advancement of patient care? And can you illustrate this with some unique examples?
Thank you very much, Dr. Eva. It's been a pleasure listening to these esteemed and knowledgeable speakers. I personally really enjoyed the conversation. I think to address the question about the UAE particularly, I think we have a very unique setup, and I think Dr. Sabah alluded to it at the beginning. There's been a number of initiatives in the UAE that have been building, like Al-Malaffi, which is that centralized patient data set, which can serve as a model for many countries. What we see, so I've had the good fortune of working across a lot of countries, started in Europe, then in the US, in Latin America, in Asia, in Africa, and now I'm based in Dubai. And so what you see is a huge diversity in the level of development of healthcare systems, even though they, for the most part, have the same issues of scarcity of resource, of increasing demand. And so the use of technology and data can, if done properly, address some of those challenges. And so I think in the UAE we have a good start. It's not without, I guess, hurdles. Obviously, we heard about the discrepancy between public data and private data. This is an issue that is true, I believe, across the globe, and very few countries have been able to get it right, and it takes a lot of work and iterations. So in form of an initial conclusion, I would say that first, having a strong push from policymakers is a key success factor. So having policymakers really drive and have the vision to use data to support healthcare outcome is an absolute must. I'll give you an example from another country. I worked on the very large hepatitis C eradication campaign in Egypt. Several years ago, I was with Gilead Sciences, who had invented the cure for hep C. And so if not for a very strong policymakers push, you could not drive 50 million people to get tested for hepatitis C virus, and then treating 15 million people and curing people by the millions. So really, I think the first message is that you need, as I think we see in the UAE clearly, a strong policy push. Then there is the private-public partnership, and I think, Dr. Eva, you alluded to some of the initiatives that AstraZeneca is doing, and I think the drive from the private sector is also going to be important. And again, the UAE serves as a good role model for the collaboration between public and private in significant sectors. I'll give you another interesting example. As part of the philanthropy of the organization I belong to, we have a research lab at MIT called Jameel Clinic that develops AI-powered tools for medicine. And so there is a tool that has been developed that is able to, based on measuring a mammography, predict the risk of occurrence of breast cancer 5 to 10 years in advance. So we ran the experiment at King Faisal Specialist Hospital in Saudi Arabia. And here again, the importance of having structured, well-curated data is fundamental, because it allows for when a new tool, when a new technology arrives, to immediately validate through well-structured data and then produce good information at the end. So this is a good and very interesting project that we're aiming to also roll out in the UAE. And so these are some examples, I believe, where obviously UAE is a good platform. It has good infrastructure and a willingness to adopt technology and move forward in patient care.
Thank you. And if you can just share some thoughts regarding that, how do we industry can encourage stakeholders better to embrace data-driven care?
Well, you know, industry, it's interesting. So I've spent 30 years in the pharma and biotech industry, and generally, you know, drug development still happens 95% of the time in the US or Europe, right? Now more and more, actually, interestingly, in China. So I guess the core question is, how do you attract some of those early stage developments into countries like the UAE? What are the regulatory frameworks that are required to bring in, you know, early stage clinical development? What are the competencies that need to exist and the ecosystems that need to be built up? Again, I go back to the first point I was making about the need of having strong policy making push and a real drive to actually attract that kind of ecosystem. It takes time. It takes a lot of time. Several countries have tried and are still trying, and it's not there's no easy recipe, as I'm sure you know well.
Thank you so much for these valuable responses. There's a little echo. We came to the end of the panel presentations. Thank you so much. It was really valuable to hear from various angles from the stakeholders. I think we have a few minutes left, 5-6 minutes, and I can see in the comment session that there are some questions. So maybe the panel members can help to answer some of these. So let's start with some questions that what measures are being taken to enhance public trust in sharing personal health data, and how UAE is addressing concerns about data privacy and potential misuse? I try to see few thoughts, maybe from the academic perspective. Dr. Hamid, you can start to address it, and then we can go around the table.
Yeah, thank you so much for this question. And actually, the communication between both the private and the public sector is very important, and also the capacity building for the stakeholders, especially for the health professionals. Maybe because they are hesitant, they afraid to share the information because they afraid that maybe there is some inconsistency. In order to comfort them and to make them feel comfortable with that, then they need the training on that. They need to know about the technology, what is the advanced technology, and to have alignment with the public in order to have the public, and because the public, they have more advanced technology than in the private. So if for example, make like workshop training for all of them in order to unify these platforms. And for example, if any patients want to go to any private sector, and he was in a public sector before or in a public hospital, they should be able to view his record or his medical record. And the opposite also the same. And they can, if he is in Dubai or in Abu Dhabi or anywhere in the Emirates, they can view that and they can know about it. And no, there will be no inconsistency with the data. But if there is a missing data, then there will be a problem. That's why how to make the private and the public feel more safe and comfortable in order to share the information or the patient's records. It needs good efforts between the public and the private, and good communication between both of them, to sit together and have like a memorandum of understanding or something like this, an agreement. What is acceptable and what is not acceptable for that.
Thank you for that. I think there was a question about what measures are being taken to, what steps are being taken to enhance the technical skills and capabilities of healthcare professionals and data analysis in UAE to better design, execute, and interpret RWE studies. Dr. Sara, you mentioned about the upskilling, the need, and part of the critical success factors. Maybe you can start the responses, and we can supplement.
Yeah, sure. So the question is, as you mentioned,
Dr. Sara, we don't hear you fully well. If you can move closer to the microphone, yes.
I don't know if you can hear me
Yes,
now.
nice.
I'm very sorry.
Good.
So the question was mainly about the technical skills and the capabilities of healthcare professionals and data analysts in the UAE. MashaAllah, we can say that in the last few years, and probably this was touched upon also with Dr. Husam, saying that the health insurance sector have already started, and that's over the years we have seen the capabilities, whether it was from the technological part or also from the data analysis part. We have seen that the capabilities have increased gradually, and the discussion have become much more discussed about real world evidence and real world data generation. Now, we have to understand that this is a journey that the whole globe is going through, and getting that required and to be utilized, it's a learning journey. So at the moment, we are seeing more and more studies that are conducted, and there are more collaborative ways to be conducted, but we do encourage everyone to go through and to really take one step forward. And as a president of Emirates Health Economics Society and going around, I also mentioned that even for healthcare professionals at their undergraduate level, we need to give some little bits and pieces of information that this is.
Oops, I think we have a little bit of technical difficulties. We lost Dr. Sara. Maybe we can try to answer one final questions. How can RWE be used to assess effectiveness and safety of new medical treatments in the real world setting? I'll try to respond to this myself, and please, Dr. Husam and the rest of the panel members, add anything you wish to. I think there is one of the largest data set in terms of how complementary and how helpful could be RWE data to randomize clinical studies is coming from the area of hypertension, which is still causing several of the major non-communicable chronic diseases. And we see several years that after the hypertensive medicines randomized control studies have been done many years ago, we still see a huge clinical treatment inertia and also very poor adherence and persistence regarding hypertension. And with several cardiac societies, they're really highlighting the fact that how important is to supplement our understanding of the RCTs in hypertension with RWE to draw attention to the lack of adherence and persistence with SMPC and the huge clinical treatment initia, which results in that it takes sometimes 2 and a bit of years to make hypertensive patients at goal. I think we have came to the end of our panel discussion today. I wanted to once again thank the panel members for their very helpful comments and valuable views to share. And I hope that with these insights, we are further contributing towards progressing value-based care in UAE. Thank you and enjoy the rest of the conference. Bye-bye.
Thank you, Dr. Eva. Thank you to everybody else on the panel. Have a good day.
Thank you.